Nigeria live. And these PACs provide mainly preventive and promotive health services. And these are the services that are most needed by the people in Nigeria. However, these services are very, very poorly funded. Rather, Nigeria would spend a lot of the budgets or the health budget on very expensive machines, sophisticated machines that are placed in teaching hospitals, and very few sector of the population has access to those kind of services. Where the people need health services in the community level, these services are not available. The flow of funds from the federal to the state and from the state to the local government is also not done in a timely manner, and also it is not done efficiently. In all, it is estimated that less than 5% of the national budget is spent on health, yet Nigeria is not as poor as many other countries that have improved PACs for their populations and reduced mortality and morbidity, even though those countries are not as rich as Nigeria and do not even spend as much on their healthcare as Nigeria. Now, government is not the only player in the health sector in Nigeria. The private sector provides up to 60% of healthcare in Nigeria. Unfortunately, when government is planning, the private sector is not usually taken into account. And therefore, the government just plans as if they're the only players. And yet we know that when that happens, about 60% of Nigerians are excluded from the government plans because those access their services from private practice. And in the private sector, which could be faith-based or not faith-based, the services are either subsidized or you pay, everything. The user bears the whole brunt of whatever the cost of that service is. So you find that most of the Nigerian population, therefore, end up paying money out of pocket for health services, and that can be very expensive in a country where more than 70% of the population lives below $1 a day. And also that limits access to a majority of the Nigerian population, particularly the women and the children, who we know have very low purchasing power. It also, another point to note here also is that both at the public and the private health sectors, the services are of low quality. And therefore, even when people pay for these services, you're not getting what you are paying for. Nigeria is a big recipient of external aid, and every year hundreds of thousands of millions of dollars get into the country in foreign aid, particularly to health and also to other sectors in Nigeria. However, we're told that all of this does not account for up to 10% of Nigeria's total health budget. And yet, when we're talking about impact, when we're talking about services, it is these donor-funded projects that give us the numbers that we're looking for. So what is happening to the over 90% of funding that Nigeria is supposedly releasing for health services, and we are not sure what those services are being funded for? You have seen some of this data, some of the statistics. I've used the DHS 2003 and 2004, and you will see that a number of, well, most of the indicators for most of the health indicators are not making much progress. There does not seem to be much change between what was happening in 2003 and what is is happening in 2008. In some cases, you actually even have downgrading of some of the indicators, and we are wondering what is happening. However, it is important to note that all of these figures are averages, and then there is a very wide disparity between the actual figures based on the regions. Nigeria has 6 regions, and most of the data coming out of the northeast and the northwest are actually worse than the national averages. But the southwest seems to be doing very well when it comes to most of this indicator. Now, we've talked about Nigeria's population, and I'm not going to go into this, but however, I just want us to note one or two things. The first one is that in 100 years, Nigeria's population has grown 12-fold. It's grown 12-fold. And in 1963, both Nigeria and Britain had the same population size of about 56 million people. However, in 2012, Nigeria has a population of about 158 or 167, depending on which data you're looking at. And but Britain has a population of 62 million. So you can imagine at what rate Nigeria's population is growing. At 3.2%, it is estimated that the population of Nigeria will actually double in less than 25 years. But Nigeria has a national population policy that is supposed to be engendering sustainable development, and some of the goals of that, or the targets of that policy, is that the country wants to reduce the growth rate to 2% or lower, and that it wants to reduce total fertility to with at least 0.6 children for every 5 years, and it also wants to increase contraceptive prevalence by 2 percentage points every year. However, we've seen that that is not happening, and we want to ask why. We want to ask why that is not happening. This just buttresses the Nigerian population. Just putting it graphically, you can see that Nigeria over there is almost squeezing all of the other African countries out of that. This map is based on population, not on the space, not on square kilometer or not on area. It's based on the population. And you can see that in 1960, Nigeria was almost squeezing the other African countries out of the map. But if we move on to 2015, you can see that it's still keeping that same population. And now, Nigeria contributes just about 2% of the total world population. But by 2050, Nigeria will be contributing about 3% of the population of the world. The main reason why this is happening is because of Nigeria's very high fertility rate. Nigeria has a fertility rate of about 5.7, and you can see from the countries that are there on the map, only Chad has a higher fertility rate than Nigeria. And so we ask ourselves why. It's not because of religion, it's not because of poverty and all of those other things, because if we look at the countries there's a mix. Muslim countries and so on, they don't have as high fertility rate as Nigeria. The main driving force for this, of course, is the teenage sexual activity, and therefore the teenage births and and therefore if you start having children early, then you're more likely to have a larger number. Also, the fact that marriage in Nigeria also is early, and so the women have a longer time of child bearing, and then more than one wife to one person, so one man can actually have up to 30 children, and then many Nigerian women still desire large numbers of children. The average is 6 per woman in Nigeria, when others are looking at 1 or maybe 2. Now, all right, so I'll just rush so that I can finish this up. Just looking at a few of some of those health indicators, just to give us an idea as to what is really happening in Nigeria. The first one is the maternal mortality rate. The average for Nigeria is 545 per 100,000 live births. But this marks a very large variation in the different regions. You have maternal mortality rates of almost 3 times that in the northeast, while in the southwest it is much less. Although Nigeria makes up just 2% of the population, Nigeria contributes about 10% of maternal mortality worldwide. And based on this figure, about 54,000 women die every day. And for this, for every 1 woman that dies, there are about 20 who end up with some kind of disability related to pregnancy and delivery. Major causes are hemorrhage, infection, hypertension, and unsafe abortion, but there are underlying causes, which include delays in making a decision as to whether to seek help or not to seek help when there is a complication. Even when you decide to seek help, where do you go to? When you get to that place, there is a delay because they have to go and make sure that they have the required equipment for that intervention. So all of those delays contribute to the deaths of so many women during childbirth. You also have issues of very high risk pregnancies, which are characterized by the low use of contraceptives, which then lead to having too many children too soon, and also when the woman is too young, or when you're having too many children. However, institutional and structural problems combined with lack of political will leave Nigerian women underserved and often desperate. All right, I'm going to have to stop, but just to say that child mortality is also an issue in Nigeria, and we have the MDGs that are trying to address some of these developmental issues, and they have their own they have funding, mainly from the debt relief funding, to achieve this. However, MDG office has even acknowledged the fact that this funding is not enough, and therefore there is need to come in with additional funds in order to support. There's a lot that Nigeria is already doing. I'll just jump to the last slide. There's a lot that Nigeria is already doing. However, there is a need for Nigeria to do more. There is a lot of political will. Nigeria has signed up to most of these treaties and agreements. However, Nigeria is not living up to what is contained in those treaties. So it's not just signing, it's ensuring that you know what you're signing and you plan to implement what you are signing. Nigeria has guidelines, policies, and coordination bodies. I've talked about all of those ministries and so on. However, these these lack the capacity to really handle the problem of ensuring that Nigerians get the health services that they need, that will also drive up the indicators. And then there is the health bill, which has been discussed in the two the National Assembly, and has actually already been passed, but it has not been signed into law by the President. We're looking forward to having that health bill signed into law, because that health bill will institutionalize a lot of the funding issues that we have with the local governments, so that they are adequately funded, and then they will be able to better support health care. Just one more slide, Andy, I'm sorry. And therefore, it's not good to be the last. And therefore, what are some of the opportunities that are there for, for interventions and so on? And I've said, what must Nigeria do? Of course, some of these things Nigeria cannot do on their own. Nigeria needs support to be able to do that. But chief among this is the need for Nigeria to ensure leadership, governance, management, and accountability. We have been talking about these issues since morning, and they are pervasive. You find them in each and every sector: health, agriculture, water and sanitation. Everywhere you go, there are issues with accountability, and there are issues with governance. There are issues with management and also leadership. There's a need for Nigeria to improve on that, and they need support. They're not able to do, Nigerians, or the Nigerian government is not able to do it on its own. So there is a need for support. Human resources, improved delivery of health services, all of those are opportunities that require support in Nigeria. Also, there's a big gap in poverty reduction. We know that with poverty, this is usually related to ignorance, which is also leads to disease. So that vicious cycle is still there in Nigeria. There's a need to break it. And then, of course, we need to curb our population growth. So thank you so much. And I'll hand over to my colleagues to continue with the discussion.
Thank you very much. Next speaker is Kabir Abdullahi, and we will beg your indulgence. I'm sure we will go over, but hopefully we will keep our audience captured for some time longer.
Yeah, thank you very much, Andrew. I want to appreciate the program on environmental development and security even for this opportunity. And I think the activities, the programs that have been laid out today were very, right, and then they provide an opportunity for us to have a clearer understanding of what the issues are in Nigeria. Distinguished ladies and gentlemen, I'm providing, my presentation is going to be on assessing healthcare and family planning in Nigeria, but basically that is a utilization statistics that I will be presenting. And there are three major underlying factors that we need to put at the back of our back of our minds before we start, which is what most of the presentations today have mentioned, and also Zipporah has mentioned, which is the birthing practices, medical skills and logistics, and then contraceptive utilization. This presentation is going to look at a number of factors, underlying factors, looking at knowledge, exposure to information, quality of services, while at the same time, that we're going to hold that as a basis for the analysis, but we're holding that as a constant, and then looking at distal factors and needs for family planning. Distal factors are cultural norms and also poverty. And then we have proximate factors, which is desire for family size, female gender preferences, knowledge, and also female autonomy. The other factors which we're looking at also looks at outcome in terms of use of contraceptives, desire to use, and also consistency of use. Those are the things I will be presenting on. Now, the outline of this presentation is on maternal health headlines, access to family planning services, programming for success, and takeaway points. Women in Nigeria approach delivery with apprehension that arises from the total number of deaths that we experience in Nigeria. Like you heard from her, from the previous presenter, 545,000, right? That is equivalent to 1 in 12 pregnant women dying. And if you look at the statistics for Europe, it is 1 in 16,000, which is about, and then in Africa is 1 in 22 women dying, which is for Africa is 750 times the number of women that are dying in Europe. And for Nigeria, that is a twofold of that figure. Some of the headlines that you've had today, and also we'll be listening to now, has to do with Nigeria is ranked 187 out of 191, partly because the total per capita investment on health is just about 10% as at 2006. Currently, it's about $8 per capita. Pregnant women in Nigeria die due to government negligence. You had that, and then of course 91%. There are a lot of statistics going up, about the total number of people below the poverty line, 91%, 70%, but the most consistent is 70%, but the recent figure indicated about 80-something to 91% of people below the poverty line. And that is really a mess, and that actually has in correlation with the total statistics that will be, utilization of health services. Now, these are the key statistics. The Nigerian woman averaged 6 children over her lifetime. The national population is the largest in Africa, and then will be expected to double in the next 25 years. By 2050, Nigeria will have a population close to about 300,000, which is in a space that is equivalent to Arizona and New Mexico. And then, of course, for us to maintain the health as it is, we have to do a lot of activity. Take huge action to ensure that services are delivered that are qualitative, responsive to the needs of the people, and also accessible to the people in terms of cost and also nearness. These indicators are much worse for poorer section of the society in Nigeria, and then the structure of health had been told. You've been told about the structure of health. Health is in the concurrent list, and Federal Ministry of Health covers tertiary institutions. The state government covers secondary facilities, and the primary health care is covered by the local governments. But incidentally, the investment, per capita investment in all of those areas are limited. The health system in Nigeria is divided into two subsystems. You have the health promotion and disease control subsystem, and also you have the sickness care subsystem. Now, for you to have an understanding of what the issues are, in Nigeria, the investment is heavier on the sickness care subsystem. You are allowed to fall ill and and present in hospitals, rather than providing you with all of the necessary information that is required to ensure your health. Family planning is a public health issue, and it requires health promotion. What people need is information to take more informed decisions. Incidentally, that is not what is provided. These are the major factors that you see in social norms, demographics, and poverty are very critical. And of course, understanding the statistics of the issues and localizing the investments that are required to change the situation is very critical for any intervention. If you just intervene, you might be intervening wrongly. Now, if you look at utilization and demand for contraceptives, you notice that consistently, Nigeria had been only able to serve half the requirement of contraceptives needs of the people. These are the current contraceptives from 1990 to the current, which is 9.7%. But if you look at the unmet need, consistently, we'll be only able to serve about 50% of the requirements for contraceptives. And this also masks the situation across the country. For instance, in Jigawa, which is in the northwest area, it is 0.3% contraceptive prevalence rate, almost nil. But in Lagos, it's about 47% of the contraceptive prevalence. Again, relationship between CPR and age group, and RH years revealed different correlation. I'm sure Nikia will be talking about that very soon. This is the statistics for use of contraceptives. The critical one is the 4.1%, which is the female sterilization, and then you have 10% for IUDs. Those are long-acting methods, and then they generate more CYP than the condoms and also the LAM. LAM is lactation anemia methods. Now, looking at when you correlate contraceptive among women with wealth quintile, you discover that the poorest are actually using are barely using contraceptives, while the richest are the ones that are utilizing contraceptives. Now, if you look at the fertility rates too, you discover that those that are using the least number of contraceptives are the ones that are having the highest total fertility and higher fertility rates. Now, if we look at needs for use of contraceptives, FP among sexually active and non-menopausal women in 2008, you discover that to get a sense of this presentation, this particular slide, we looked at the cultural. You look at the urban and disaggregated by urban and rural settlements, and then also those that want to use, those that are currently using, and those that consistently use for 2 years. You discover about 60% of that figure for those who want to delay and then also end childbearing, that is desire to use. Ever used is about 50%. But when you correlate with those that have consistently used, you discover that it's just about 10%. And that figure is also reflected in the same way in the rural areas. But the difference is the fact that it matches the earlier presentation of not being able to meet the unmet needs for family planning in Nigeria. And then when we look at the percentage of women, urban women with favorable proximate factors by religion and region, looking at cultural norms, you understand? Low ideal family sizes. You discover that northern Muslims, have desire for large family sizes. That is why they're indicating low desire for ideal family sizes. If you compare that with other high participation in household decision making, it's low for the northern Muslims, and also knowledge of method mix is also low for the Muslims, northern Muslims. And then, but what they do not do is that they do not have gender preferences. Or this, incidentally, if you look at other southern Muslims, they also have a slight tendency, similar to the northern Muslims, but a better, in terms they have lower family size desires, and also they participate in family and household decision making. Now, if you look at urban women with favorable proximate factors by wealth quintile, you discover that the upper 2 quintiles have the desire for lower family sizes, while the lower quintiles have desire for large family sizes. And participation, that means if you correlate wealth with all of these other 4 factors, you discover that they look favorable. That means poverty is significant, it's very critical, it's important in knowledge, in terms of awareness, in terms of utilization, and also in terms of use and consistent use. Now, if you look at sources of contraceptives between the public and private sector, you discover that most of the long-acting methods are sourced from the public sector, while the the reversible methods or the reuse methods, that is condoms, condoms, injectables, and also pills are the ones that are common in the private sector. What this is saying is that those that require skills for delivery are available in public sector, but those that require little skills for delivery are actually the ones that you get in pharmacies and chemists. That is why the statistics, you notice that these are all pills and these are all male condoms that you see in private sector, but the public sector provides long-acting methods. That means emphasis should be within the public sector, while establishing relationship and ensuring that services are delivered within the private sector and standardized. Now, if you look at the BAT assisted by health personnel providers, you discover that the poorest have the least BAT assisted by professionals, while the richest, because the richest are the ones able, they have information, have access, and they can challenge the system. The poor, because of poverty, do not even approach facility because they do not have user fees are charged, and they avoid going to facilities. So most often they deliver at home. That's why the statistics also, every bite comes with its risk. And because of that risk, most of the time you discover that the poorest are the ones that are dying, while the richest are the ones that have a better health outcome from pregnancy. Now, if you combine CPR, looking at the regions, different regions, there are 6 geopolitical zones. You look at CPR, where you have the lowest CPR, you have the highest total fertility rate, and then you have the highest maternal mortality rates. For instance, look at Northeast. They have a CPR of 4.0, 7, and then they have TFR of 7.2, but very high maternal mortality rate. Now, if you correlate that with the Northwest, it's the same socio-cultural environment, but the difference is the fact that there is more poverty in the Northeast than in their distance. That's why their own figure is even worse. And then you come to for instance, Southwest, you discover that Southwest has a figure that is equivalent to the developed world, 165 per 100,000 live births, maternal mortality rates. And then they also have very good, fairly good CPR, and then TFR is just 5 births in the lifetime of a woman. Now, in summary, what this is saying technically is that use of FP services is slow and stagnant. There's limited knowledge of methods. There's also limited FP discussions. Concerns around method safety is significant. Availability and affordability issues are also critical. That means issues of quality around services, commodity stockouts, and cost are significant factors for delivering health services. And then, of course, enabling environment is the fact that family planning is not prioritized, is not budgeted for, and where the budget is, in some instances, it is insignificant to deliver the services. For instance, in the last year, we had a budget gap for contraceptives in Nigeria that is equivalent to about 60 million US dollars. And then the government could not provide for that. Eventually, they budgeted how much? 3 million US dollars out of 60 million that is required. But incidentally, looking at that statistics, the international organizations now pulled Jonathan into a committee to ensure that he prioritizes, he understands what the issues are, and then to be shamed. You understand? That's in shaming him. In Nigeria, within the Nigerian culture, if you shame somebody, nobody wants to be shamed. So they will do something not to be shamed rather than do the right thing sometimes. So I think that's the principle that is being utilized here. Access to reproductive health and family planning in Nigeria is fragile, weak, and dependent on donor funding. Fertility remains high, contraceptive use is low. The road towards to tight reduction in maternal mortality is going to be very long. Poverty is clearly it's clearly linked to both maternal mortality and service uptake. The health system needs to develop strategies that target poorer people. Skilled care without required equipment supplies is not sufficient. Political and financial commitment to equip facilities is crucial. Donor programs are important sources of financial and technical resource inflow. However, strong coordination is required to maintain the gains. Government has not prioritized FP. Other considerations are health financing. You had much about health financing from the previous presenter. But then, of course, one important thing that is happening is the fact that that's revolutionizing the system is the fact that health insurance has come into the fold. For the public sector employees, they are accessing health insurance. The private sector is also, in some instances, accessing that. What we need to do is community health insurance. Once we are able to get community health insurance system into position, then the health of our women will improve. And then, of course, doctor-to-patient ratio. Currently, I think the doctor-to-patient ratio is about 1.28 per 1 million, which is equivalent to about 1 doctor to about 33,000. But the ideal is 1 doctor to about 500 to 1,500. Now, for us to improve, we need to strengthen the system. We need to generate demands. But in generating demands, we need to look at the differentials between the North and the South. We need to remove demand-side barriers, social norms, women empowerment, financial barriers, and also physical barriers in terms of location. The Nigerian Urban Reproductive Health Initiative is a 4-country project that is funded by the Bill and Melinda Gates Foundation. It attempts to address all of these issues. What are the issues? The issues are birthing practices, limitation of medical skills and logistics, and also low use of contraceptives. In delivering our services, the vision is to eliminate demand and supply barrier for contraceptives, and then the goal is to increase contraceptive prevalence rate by 20 percentage points. And we're going to, and then the objectives, there are 5 objectives that are bundled into 3 components. The first 3 objectives, you can read it up in the website. The first 3 objectives are service delivery objectives, and they are critical. What we are doing is ensuring that services are made available, qualitative, cost-effective, and also responsive to the needs of the people, looking at different regional variations. And then, of course, we're doing demand generation, huge demand generation activities, and then we're also doing advocacy. Our advocacy have recently generated resources within the states and local government services to deliver these services, to ensure that women can access services. So we are creating an enabling environment. We have been able to increase government resources, increase media coverage of family planning. We're changing the norm of secrecy around family planning. We have also been able to increase public support for birth spacing. We've increased services. We've increased CYP generation in high-volume centers, and we have gotten communities to participate and also to begin, to speak out, particularly traditional and religious leaders. And you understand for traditional leaders to speak out, they need to test the environment very critically. In Kaduna State, we went to the Emir of Zaria, Zazzau, 6 times, and each time he was expanding the audience. Each time he expands the audience, different audience, and he was testing to see what is the response, what are the feelings of the people. And eventually he spoke out and said, birth spacing is critical to the health of women. And that is on our website. You can check the website and you see where he spoke out. And then the video is there, and the scripts are there. And we also had a roundtable discussion with traditional religious leaders where they signed off on a communique and calling on government to increase funding availability, calling on community leaders to support, calling on religious leaders to speak. And eventually we had a roundtable discussion with religious leaders, and they signed off and said, birth spacing is critical to the survival of women women. So these are changes that are happening in the environment because we are using a model of bottom-up approach. We're discussing with the community and ensuring that the community understands what the issues are and appreciate the fact that they critically need to take action before changes can begin to happen. We're asking religious leaders to look back and reflect and see how many women are dying in their community. In the last 1 month, how many people have they done ritual birth rites on? How many of them were women? How many of them died as a result of anything related to birth, either pregnancy, giving birth, or postpartum period? And because of that reflection, understand, they are beginning to appreciate the fact that giving birth too frequently, too often, too soon or too late in life are the critical factors that are leading to maternal mortality in their environment, so they're taking action. Individuals are also beginning to gain confidence and also accessing services. They are motivated by a number of media mix of information. We're providing them information, we're changing their perception, we're also doing social community-based mobilization within their environment, and we're using people from their own environment to speak to them because they speak the same language, they understand them, they know them, and they have trust in them. Now, what we have learned from all of the activities that we have done is the fact that comprehensive site assessment is critical to success. If you use statistics that resonate with the people in the environment, then they appreciate the issues better, rather than bring in something and then you want to push it down in their environment, their way. And then, of course, you need to involve early in terms of in the planning process for them to appreciate the issue and then bring up the challenges, and then eventually devise the solutions. Often, the solutions they devise align with your own solutions once they are properly guided. The opportunities available as supportive policy environment that are emerging, and also the free contraceptive policy in Nigeria that has happened. We're using a mix of communication channel, mass media, interpersonal communication, community mobilization, web, and emerging social network opportunities for youth programming has also grown. Religious and traditional leaders are beginning to speak out and declaring support for family planning and child participation in services, and we need to use their medium to engender. You need to appreciate the fact that religious leaders have tremendous power of speech, and they have followership. And at the same time, when they speak, people trust them because they speak theology, they speak to the minds of people and to their heads. And for that reason, you need to engage them strategically. So that is what we have done in Nigerian Urban Reproductive Health Initiative. Now, the takeaway points for us here today is that family planning, maternal and new child-born health have substantial and measurable impact on the health of women and their families. Understanding the interplay of the variables provide insight into opportunities to improve access and utilization of family planning and MNCH services. MNCH is maternal and newborn child health services. And then disparities exist among states and between the different zones that might not be unconnected to the decentralized nature of health delivery services in Nigeria. Literacy levels, rural-urban locations, social-cultural norms as demonstrated by the interplay of CPR and demographic variables are critical. Programs must therefore place these differentials on their radar for them to succeed. Women who are poor and have little education have lower CPR, indicating effect of socio-economic variables on service uptake. There's also evidence to support male involvement in the use of FP services emanating from husband's opposition. That is very critical. Now, of course, men determine what happens. And then, of course, the analysis suggests that programming in Nigeria, efforts must target unmet needs and demand in southern Nigeria. But in northern Nigeria, you need to pursue advocacy critically, and engage people, target them in terms of increasing knowledge, rights of women, rights to health and survival, and need to subsidize services. Thank you.
Thank you very much, Kabir. Our next speaker is Nike Esiet, and thank everyone for staying this long, and this is our last presentation, and I hope we'll have a chance for questions after.
Thank you very much for being here at this time. Pauline said she was the only thing between yourselves and lunch. I'm the only thing between yourselves and going away. And I appreciate your being here till this point in time. First of all, to thank the Woodrow Wilson Center for having me speak here and for prioritizing the issues of young people, adolescent health on this panel. I would like to say that it's the priority that we give to young people that makes me the last speaker here today. I'd like to turn it around and say to have the last word, the issues of young people has been put on this agenda. When we say adolescents, I'm sure we know that we're talking about 10 to 19-year-olds or young people 10 to 24-year-olds. And why adolescent sexual and reproductive health? First is a population issue. We've heard the population of Nigeria. And Bola Tito did a great job this morning showing us the youth bulge in Nigeria. I came a long way down. I don't know how to talk and manipulate technology. Thank you. We're talking here 30 million Nigerians between the ages of 10 and 19, or 1/3 of the population, about 50 million people between the ages of 10 and 24. So talking about adolescent sexual and reproductive health here, it's truly a population issue. It's also a health issue. More than half of the new HIV infections in Nigeria are accounted for by people under the age of 24, with girls being disproportionately affected. For every one boy that's an adolescent who is HIV positive, you have 3 girls. It's a natural resources issue just as well. 2 of the least resourced northern regions in Nigeria, the Northwest and the Northeast, account for 42% of Nigeria's 15 to 19-year-olds. Yet these girls, who are demonstrably the least educated, the least empowered, account for 71% of all births within that age group, with their fertility rate being 7.2, higher than the national average of about 5.7. Adolescent sexual and reproductive health is also a governance issue. These are the young people who will govern Nigeria, with no education, and for the women, limited agency and a means of managing their own fertility. And of course, the answer to the adolescent sexual and reproductive health challenges facing us as Nigerians implicates the health sector, the public sector, not just the health sector, it's the education sector, the environment sector, and the youth development sector. So what I'll be trying to do with the limited time I have here, and I'm going to really try to be on time, is to try and get clarification to the issues, the following issues. Who are these adolescents or young people that we're talking about? What is adolescent sexual and reproductive health, and what challenges face us in assuring this? What factors contribute to these challenges? What needs to be done? What is being done? And what else is needed? I think the primary key to understanding and applying solutions, and I'm trying to jump to the, my key message from the beginning, is understanding that when we say adolescents or young people, we're talking about a diverse population. I like to say as diverse as Nigeria is, because you can see that there's great diversity in Nigeria. Are we talking about early adolescents, 10 to 14, 15-year-olds, or those 20 to 24? Because the way we would approach these different age categorizations are different in terms of the services that we're going to be providing. Are they male or female? Where do they reside? Are they in school or out of school? Are they living with their parents? Or are they parents themselves, heads of households? Are they married in monogamous, polygamous arrangements? Or they're just cohabiting or not married? Are they displaced, employed, unemployed? These are the questions we need to ask when we're categorizing young people. And this is the key to applying the solutions we may want to project. So when we say adolescent sexual and reproductive health, we mean the physical, mental, emotional well-being of young people that includes the freedom from unwanted pregnancy, unsafe abortion, maternal death, sexually transmitted infections, including HIV, and every form of sexual violence and coercion. I'll jump this slide. So what's the reality? of the young person's sexual and reproductive health in Nigeria today. They're highly vulnerable to HIV infection. I've said that already. More than half of new infections occur among people under the age of 25. And for girls, it's not a joke. Girls are burdened with unplanned and unwanted pregnancies, too early and at great risk. Of course, we know that teenage mothers are typically physically, emotionally, and economically unprepared to take care of children because they are still children themselves. And evidence on the ground shows that teenage mothers are twice as likely as older women to die from pregnancy-related causes, and their children are more likely to die in infancy. Meanwhile, more than half of females in Nigeria have had a child before their age 20. And hospital data shows us all of the time that girls are bearing the brunt of complications from unsafe induced abortion. And this is a long-standing Nigerian story. When my organization started in 1989, that was the reason for starting. Girls dropping out of school because of pregnancy, girls being chucked out of school, and my organization is based in southern Nigeria, so my knowledge of what these issues were limited to girls in school, wanting to go to school, not wanting to carry a pregnancy to term. But the diversity of Nigeria shows much more than that. Many girls are married off at early ages, and that's part of the diversity of Nigeria. The greater proportion of girls who are getting married come from the northwest and the northeast regions of Nigeria. 50% are married. In fact, in northern Nigeria, 2/3, much more like 75% of girls are married by the time they're age 20. Of course, this violates the rights of these young women who are still minors because they can't be consenting if they are minors. It means loss of schooling opportunity and livelihood opportunities, and all of the issues that come with risky sex, because these girls are marrying men who are far older than them, that have multiple partners, not just the girls. So the risk of the issue about talking about marriage being protection actually does not really apply. Of course, for sexual abuse, it's occurring at epidemic levels. Unfortunately, there isn't enough data available out there. It includes harassment, unwanted sexual contact, coercion, rape, commercial sex work, child trafficking, and the perpetrators many times are not strangers to the girls. They're family members, teachers, gatekeepers, religious leaders, and the girls, of course, are at higher risk of exploitation. What are the drivers of the sexual and reproductive experiences of young people in Nigeria? They're economic, social, and cultural factors that influence their poor health status. Overwhelming poverty disposes adolescents to high-risk behaviors and pushes parents to marry off their daughters. Their socially prescribed gender roles undermining young women's agencies and their ability to protect themselves. And it's common for girls to have sex with or get married, given away in marriage to considerably older men who are sexually experienced, while boys the same age have more sexual partners than girls their age without use of protection. Of course, a major driver continues to be the denial amongst adults of the fact that young people are not asexual. In the midst of all of these negative sexual and reproductive health indicators, adults would still rather believe that young people should not have access to services or information. This is a major driver of the continuing poor health indices of young people. We know what needs to be done. Nigeria is replete with many intellectuals, not just in country, abroad. There are many civil society organizations with good knowledge of what needs to be done. And there's a strong constituency of civil society organizations that have been advocating for these issues over time. And there's substantial public resources, public funds available. And as we've heard, it's the management of those resources that continue to draw us back as a country. What Nigeria requires, we know, is a comprehensive approach and coordinated support from all sectors. The health sector, the education sector, with providing sexuality education, social awareness amongst the community about gender roles and how this is discriminatory to the health and well-being of young women, and reliable public infrastructure to ensure that people can access services and know where to go when they need to go. So the information and knowledge of what needs to be done is out there. And what's being done? Nigeria is replete with policies. When Action Health Incorporated, the organization I co-founded, started in 1989, the issue was, where's the National Adolescent Health Policy? Where's the health policy? Because we always say, you know, you create an appropriate policy environment that's supportive of an issue that you want to promote. In 1995, Nigeria promulgated its National Adolescent Health Policy, just 1 year after Cairo. In 1999, Nigeria had the first national conference on adolescent reproductive health, convened by the federal government with the participation of civil society stakeholders. A national framework for adolescent reproductive health was developed. It wasn't costed at that point in time. 10 years down the line, in 2009, civil society organizations that were part of that process decided to collaborate with government to take stock. What has happened from 1999 to 2009? What did we find? Not much of the policies and plans had been transformed into anything. In fact, save for contributions from international organizations, donor agencies, Nigeria's government has not been budgeting or allocating resources to address the issues of adolescent reproductive health. Even though we have the policies, we like to say that Nigeria would sign every funky policy, any beautiful policy that comes up. We're the first to sign. Sticking by the letters of the documents we've signed, you know, truly becomes an issue. I will be doing this service to progress that's been made, you know, because Nigerians are the ones who give ourselves the greatest tongue lashing wherever you find us. I think one of the lessons I learned the first time I came to America many years ago was that every American is proud to be American. And I was asking myself everywhere I go, everywhere I went at that point in time, anything I say about Nigeria is all the things that Nigeria isn't doing. But the truth of the matter is that there's progress that's been made in Nigeria. It's just that progress is just too slow. If there's anything more than slow, that's how progress goes. So when I listened to Bola Tito in the morning, she said, you know, they're trying, they're doing something. The point is, for how long are we going to wait for something to translate into the real thing that we're looking for? Our balance is no problem. There's problem. In fact, there's fire on the mountain, and getting there quickly is what needs to happen. One of the key things that's happened in Nigeria, not because I've been involved with that process, is the fact that Nigeria is one of those few countries in the world that has a national sexuality education curriculum, a program. It's now called, when it was developed in 2001, it was called the National Sexuality Education Curriculum. But like every other thing in Nigeria becomes political, and it's what the North wants versus what the South wants, the name had to be changed to the National Family Life Education and HIV Education Curriculum. And that's something that's done well, because based on the policy, the government kind of directed that the curriculum be implemented across the federation. So the nation's response to the HIV epidemic within the education sector is this curriculum. Unfortunately, resourcing for this curriculum is very poor. Teacher training, resource materials for students, support for teachers in the classroom is not being budgeted for. A lot of dependence continues to be on international funding. And you know, with international funding, the strings are also attached. Rarely do any of these programs, and I can't blame them, go beyond the piloting, maybe in a number of local governments. The truth is Nigeria is a big place, and no international donors' resources can deal with the issues of Nigeria. Nigeria needs to wake up to its own responsibility. Many of the programs are also existing within the context of places where they believe that young people can be gathered easily, mainly in schools, school-based programs, when we know that there are hundreds of thousands of young people in Nigeria who still are not in school, especially girls. I've spoken about the issues of funding and, of course, the poor coordination between those programs that exist within government and the work that non-governmental organizations are currently doing. What else is needed? Like I've said, there are many programs in Nigeria, trying to promote access to youth-friendly services, promoting access to the curriculum, livelihood skills that need to be scaled up. We've learned many lessons in terms of best practices across the world and best practices even within Nigeria. But evidence-based advocacy is needed urgently to ensure that these programs go to scale. We spent enough time on piloting. We can't be on the slow lane anymore, because as we speak, the youth population is growing and the problems are not about to disappear. There's also need for rigorous evaluation and sharing of lessons learned thus far in terms of effective programming as these programs are being scaled up. Programming also needs to be cognizant and responsive to the needs of the various categories of young people. As you've seen, previous speakers allude to the fact that many girls are married by the end of their teenage years in northern Nigeria. Many more girls are delaying in southern Nigeria because girls are staying in school. The longer a girl stays in school, the less the likelihood that she's going to have a child, before she's 20. So programming needs to be responsive to the life circumstances of young people, the different life circumstances or contexts within which they find themselves. Money, money, money. The Nigerian government needs to, stick to where, how do they say it? Now the English is gone. Walk your talk, basically. We can't be signing on to these policies and not allocating resources to ensure that programming truly happens. And the CSOs, civil society organizations, continue to have a responsibility to hold government accountable. Time is gone when we're going to say that government is not doing it. We've seen from what happened with the last elections and with what happened in January with the removal of fuel subsidy, that civil society organizations and the community at large has a responsibility to move government ahead, and this needs to happen in the youth sector. There needs to be more multidisciplinary public-private partnerships to bring about synergy in addressing the issues of young people. The private sector hasn't been involved thus far, and that's a big source of funding for programming for young people. And so civil society organizations with substantial experience of working in this area need to be included in the accountability mechanisms and support government efforts in this regard. Thank you so very much for listening.
Thank you very much, Nike and all the presenters. I hope we have time for questions, and I'm sure there's lots of questions out there. And if you can stay, and if you can stay for multiple rounds of questions, we'd be happy to entertain them. I think our speakers are very eager to engage the audience in a dialogue. So maybe the best thing would be to quickly take 3 questions and then open it up. Why don't you go ahead and I'll just...
Thank you very much. I would like to commend the 3 speakers for job well done, and also trying to really give us the picture of what the various aspects of the issues they addressed are. First to Madam Nike, I would like to ask, in terms of early child marriage, the issue of VVF as regards the North was left out. I don't know how you, the implication of this as regards the health of the girls in early marriage. Dr. Kabir, in the area of public health, we notice a big gap in this aspect, particularly when it comes to the issue of engagement of environmental health workers who are also supposed to work with the communities. Because from what we could see, most of the issues we address seem to be issues within the urban areas. But there are a lot of issues that have been in the rural areas that are not really pictured in the presentation. Because if we talk of the issue of facilities, you see that if there are facilities at all, it's just that you have one health personnel in one health facility. And getting expectant mothers or pregnant women to go for antenatal, you don't have the kind of facilities you have in cities. So at the end of the day, it's just to have it on record that these ladies attended the facilities, but there were no facilities to check if there are likely to be complications on these mothers at during childbirth or at delivery.
Okay, thank you. Let's see if others have questions as well, and if there are, we'll take them now and answer them in order. If you could also introduce yourself before you ask the question, please, and your organization, if you have it. If there are none immediate, yep, yes, please.
Judy Asuni. I have a request, not a question. To me, what's really struck me during the day is that the numbers speak for themselves, and I'm not sure that the numbers are always out there. For those of us who work using social media, for example, to mobilize people on governance issues, is it possible to get copies of these presentations that we can put on our websites and our Facebook pages with links and stuff like that? Because I think when people see the information, it's very striking. For example, in the Niger Delta, people always feel that they are maligned. You know, they're not getting their fair share of development. But when you see the figures for the Northeast and the Northwest, it's extremely dramatic. And I think this can help us in fighting our battle for better governance if these are available. So this goes back to the organizers of the program. Can we get these either in PowerPoint or in some sort of a written summary that we can actually pass on? Thank you.
And one more question, and we'll take the answers, please.
Is your answer?
Or is that an answer?
It's a, well, I'll ask a question too, but I'll also first answer that, which is, yes, the PowerPoints kind of with permission of the speakers, are all on the website, and in fact, most of them should be there already, so that people watching the live webcast could follow along. That's at the wilsoncenter.org, then probably either /Africa for the Africa program or /ECSP for Environmental Change and Security Program, as will the archive video, as will a write-up, kind of summary write-up of presentations. And then also we urge all of you to share with us what you see as valuable links that we can include in that, obviously to the various organizations, but there have been a number of reports and surveys and such that have been highlighted throughout the course of the day. Hyperlinks for those so that we can really make it as rich as possible in connecting people to the variety of different research and kind of policy, research resources and policy cases would be terrific. My question is one that has kind of come up in presentations and in hallway conversations, and so apologies if it's repetitive, but it is of special interest to us here. As you noted, obviously we've integrated some of these environment, natural resources, health, and population topics. And some of our presentations have alluded to some of the integrated efforts to address those. The so-called either population health environment programs or HELPS projects, the health kind of health environment livelihoods population projects, are ones that kind of intuitively make a lot of sense given these interconnections, are really hard to do because money's meant for one thing and not for another, and because some organizations do environment or do health, and they don't want to either don't have the expertise or don't want to get into areas where they feel they aren't expert. And so if the panelists have any reflections on are you seeing kind of dynamic examples of this integrated programming in Nigeria? Would love to hear about it, and or tell us about some of the barriers. The places that we've heard the most from, usually kind of projects that are supported by AID or the Packard Foundation, have been in Madagascar, Rwanda, Ethiopia, Uganda, a little bit in Kenya on the continent, but really not so much at all in West Africa, and so would love to hear more about that.
Thank you. Well, let's get responses to these. Let's go in reverse order with Nike first this time. And if you could, each of the questions, or whichever of the questions you feel is applicable to you, please address. Thank you.
Okay, I think the direct question was that my presentation didn't talk about VVF. Yes, you're correct, I didn't mention VVF, but truly the complications of early childbearing is one of the primary risks, is coming down with vesicovaginal fistula or rectovaginal fistula, or what's RVF. And this is a continuing big problem, but it's just one of the experiences that girls having children early have to go through. Death is the first complication, as we've heard from the figures around maternal mortality. The high figures in Nigeria are driven by these girls. Issues of infertility also arising from trying to terminate these pregnancies on their own. So yes, VVF is one of the major risks that the girls have to deal with.
VVF. In northern Nigeria, incidentally, the VVF issue is a phenomenon. It is a phenomenon because if you reflect back into the culture, a woman is not woman enough if she doesn't deliver through the vagina. If she has a CS, then she's not woman enough. I was in a program in Zaria, in a community, in a hospital, in a secondary facility in Zaria that University of Berkeley, California was also involved in. We did an ethnography. And I went into that, the labor room, and this woman had vaginal prolapse. Hand prolapse. That means the baby is coming with the hand and the head so she can't deliver by herself, and that's her first pregnancy, and she's very young, about 15-year-old, and her cervix is not wide enough to allow the baby to pass. Now, those incidences are very common in much of northern Nigeria. And she was saying, oh my God, oh my God. And then she was also saying, I don't want to be operated on. Now, that is going back into the culture. You understand? The people, she's saying, Wayo Allah, Wayo Allah. And then she's also saying, Bana son theater. Now, theater means operation. She's saying that because if she returns home, she's considered as not being woman enough because she didn't deliver by herself. She was assisted. Eventually, somebody came in, and then operated on her. If she wasn't operated on, she would have died. Now, with that kind of situation, you understand, you have to deal with you have to deal with the cultural issue, that's the social norm, by providing information to them, and changing the perception. So VVF has a direct relationship with poverty, with early marriage, and also with a woman, a girl not being matured enough. Of course, you have VVF too in older women. A woman that has given birth too many times and too frequently is also likely to have that kind of situation. You understand? So VVF in older women is common in the south, but VVF for younger women are more common in the northern part of Nigeria, incidentally.
Yes, and to continue to talk about VVF, which stands for vesicovaginal fistula, and that's a hole between the woman's, the vagina and the bladder, that is brought about by, necrosis. When there's pressure of a soft tissue between two hard tissues, the head of the baby and the pelvis of the woman, blood supply is cut off, and then that area dies off, and then it sloughs off and it leaves a hole, and then the woman is leaking urine, wherever she goes, and it's not a good. Those women are usually ostracized, and they're just social outcasts because everywhere they're smelling urine, and nobody wants to associate with them. Even their parents sometimes throw them out of the house, and it's really a very big problem. Nigeria is actually one of the few countries in the world where we still have an issue with VVF, mainly because of early marriage and early childbirth. And my colleagues have talked about what we need to do with regards to addressing the issue of VVF. Then also engaging environmental health workers in rural areas. That has become an imperative for Nigeria. Nigeria has realized that it can no longer do business as usual. There is a need for them to integrate. So they're integrating health into social services and into environmental services, into all kinds of things. They're just trying to see how much they can do with the very few resources they have, and those few resources include human resources, financial, and then also equipment and so on. So you find that a person, let me talk about the health sector now. What the health sector is trying to do is, it's not possible to have doctors in all PACs, which is ideal, but we know that we can't have that. So what are we doing? We're training other health cadre to be able to do some of the things that ordinarily doctors would have done, and they do that under supervision. And then we tax shift some of these chores, to them, and they are at lower levels, at community level, and they're able to serve a bigger number of clients at that level. That increases access to to everybody, particularly those who are most vulnerable, because they cannot travel to access those other facilities where you have the doctors in the urban areas. So we're doing a lot of tax shifting. And then with regards to integration efforts for population health and environmental issues. Not that I have an example right now, but I do know that there is a need for this integration of services, particularly in areas where you have crisis, like well, that is almost like in all the regions in Nigeria. We just talked about it this morning. It depends on what you're talking about. Are you talking about militancy? You're talking about Boko Haram? You're talking about religious and indigenous issues? I mean, it's all over. So when you look at that, usually in crisis, you have a lot of human rights abuses, particularly ladies, they're raped and those kind of things. They have children who they cannot cater for, and therefore it leads to social issues. And so there is a need to actually integrate these programs, because one definitely leads to the other. I mentioned the reversal of some of the health indices earlier on, and this is not unrelated with the crisis that we have all over the country. When people are running away, they're running for their lives, they're not stopping to think about the malaria that is going to kill them in the next day or two. They're not stopping to think about, oh, I need to go to antenatal next week. They're not stopping to think about the need to deliver in hospitals. Even if they think about those needs, where are the hospitals? They go to those hospitals, they're empty. The staff have been chased away because of crisis. In the project I work on now, we support a clinic in a border area between Nasarawa State and Benue State. And recently there have been communal clashes in that area. And so the health workers have run away. Now, we have about 50 patients who are receiving HIV drugs from that clinic. And when they come to access service, there's nobody there to give them the drugs because the staff have been chased away. And so these people go back without their drugs. And we know with HIV, you're talking about resistance. And then when you talk about resistance in HIV, I mean, it opens up a whole lot of doors. So there is a need to integrate these services.
And to quickly just to add in terms of environmental health programs, and historically the trachoma and onchocerciasis programs in Nigeria and in Northwest and Northeast did very early on, 60s, 70s, 80s, and eradicating in the 90s, were just that, were community-based interventions looking at both sanitation and environmental health and health provision. And those were very effective programs. Unfortunately, they haven't been repeated with other disease categories, and this has been the real challenge. And the focus on vertical programming leaves us with those discrete choices. So there's been a lot of focus on VVF as an intervention area because it's so present and clearly so needy, but that's a very late indicator of all these causal factors that have come along. And so certainly that has to be addressed, but if new entry into a new injury keeps repeating, then clearly we're not doing enough in terms of prevention, and which our speakers have addressed. So I'm realized it's very late, and I appreciate everyone staying around, and I would welcome everybody to ask further questions after the session is closed and speak to the speakers directly. And I would like to give a round of applause for the speakers.